Um, we have been doing these educational sessions for the past several months now, where we've given several topics that are relevant to the care of our patients, especially here in the ICU. We tried to be very mindful of the topics that we selected. But this month, I want to kind of do things a little differently here. I want to use this time as a little bit more of a talk, more than a lecture, so to speak. I started this position several months ago, and during our first meeting, I think we broadcasted that to everybody, and hopefully everybody here had a chance to partake in that phone call, that meeting. But really what I tried to do at that first meeting was lay out what my goals, what my expectations were, and kind of give like a general overview about my thought process, how I wanted to approach things here in the ICU. One of the things that, I was looking at social media just this morning as I woke up, as I do most mornings, and I saw this thing on my feed that listed the bottom 5 states as it pertains to healthcare, right? And I don't want to get political or anything, but Georgia ranked number 3, all right? In that bottom 5, or I guess number 47, however you want to look at it. And that it just highlighted challenges in terms of access to healthcare, actual care in hospitals, outcomes, maternal fetal mortality, all these things, right? And so there is a real issue going on in terms of healthcare here in the state of Georgia. And I bring that up to say that we can see our patients getting sicker. We can see our patients, there's more patients coming here to the hospital. There's more patients showing up to our ICU, and that's an issue that's going on everywhere. But what we can do here, especially in our ICU, is do things that help improve outcomes, improve the lives of our patients. And one of my goals here is, if you look at the whole state and you see all these issues going on, I want to see one little blip in green when you look at the map that's just south of Atlanta, our hospital. And I think that we can affect real change here, and it just permeates through the rest of the hospital. But that's one of my big goals. And we've started to implement all these different plans, all these different processes over the past few months. And I know that you guys, boots on the ground, have been feeling a lot of change with that. But I think it's important to just take this time this month just to kind of highlight and zoom out and look at things at a 30-foot view, and the reason why we're doing this. And that's where this talk comes in, our A to F bundle. So when patients come into the ICU, they're sick, they're really sick, they're the sickest patients in the hospital. There was a couple of studies years ago that looked at a patient's care through the ICU, outcomes, and they started to implement these different bundles in terms of things that we can do in the ICU to affect outcomes. And there's been studies that have been done throughout the decades, but then in 2019, there was a study of about 15,000 patients, 68 academic, community, federal hospitals and ICUs that looked at a particular bundle set that really affected change. And what we can see is that when we focus on a couple of particular areas in patients' ICU care, that really affects change. Because when patients go through the ICU, a lot of things happen to them, right? When they come into the ICU, they're sedated, they're really sick, they lay up in bed for several days, they have physical issues once they leave the ICU in terms of ICU myopathy, weakness. These folks are oftentimes deconditioned. There's cognitive issues that we often see when patients leave the ICU in terms of impaired memory, attention, executive function. There's also psychological issues that these patients often deal with. I know people in this room that have had family members that have gone through ICU care. There's a couple of folks that have been in the ICU themselves. So you guys are familiar with this on a personal level and when we're taking care of our patients, and you've seen this. So, the study in 2019 looked at particular elements that we can use to affect change in our patients. And they named it the A to F bundle, right? And these are the 6 elements that we can use to really affect change in our patients. Assessing, preventing, and managing pain. B, both SAT, SPT. C, choice of analgesia. D, delirium, early mobility, family engagement. The closer we adhere to these 6 items, the better our outcomes. And the better our patients do, the quicker we are able to get our patients out of the unit, and the better change that they have, the better effective change that they have. So I want to take a second to kind of quickly go through these. A, assessing, preventing, and management of pain. So raise your hand if you have been a nurse for 2 years or less. 2 years or less. Awesome. Okay. So I want to speak to you guys just for a second here. The way that I want to kind of go through these is to bring up a case. So, and you guys can use collaborative efforts here. So say you had a 68-year-old man that came in with septic shock, altered mental status, and got intubated, okay? And you have just received handoff from your previous shift nurse, and you go into the room and you're assessing your patient, and you see the patient nice and calm, right? Eyes closed, hands at the sides here, resting on their back. They're on the ventilator, but the ventilator is going off, right? High peak pressures, whatever, the vent alarm is going off. And then you assess a little bit further, and you see that the patient is clenching down on the ET tube, right? But their face is relaxed, arms are relaxed, they're not moving or anything like that. So you're trying to assess their pain. So what's their CAM ICU score? It's a collaborative effort. Can y'all shoot out a number? What's their CAM ICU score when you're trying to assess pain?
3.
3? Okay. So good answer. So my first comment there is, are we using CAM ICU scores to assess pain? CPOT, right? So this is one of the reasons why I want to focus in on the A to F bucket, right? Because it is important that we're speaking apples to apples, right? And drilling down on these things and honing in on these particular elements, because we have to have a good understanding about what we're doing here and how to assess our patients in order to affect change, right? So when we're managing pain, there's a couple of scales that we use. The one that we use here, the most common, is the CPOT score. And just really quickly, the CPOT score, we're looking at the muscle flexion, tension, we're looking at facial responses, we're looking at ventilators, and we're looking at any sort of purposeful movement, that sort of thing. In that particular instance, that could throw you off a little bit, right? Because the patient's nice and calm, they're not moving a lot, face is nice and relaxed, but they're clenching down on the breathing tube, so you do have some muscle tension there, and the ventilator, you have some asynchrony there, you have some alarms going on. So that CPOT score, based on those things, even though that patient looks relaxed on the surface level, that patient has a higher CPOT score, and we need to address that. So the reason why we want to pay closer attention to pain is because we know that patients in pain, that increases their risk of delirium, that increases their days on the ventilator, ICU days, worsens their outcomes, that sort of thing. So this is a thing that we need to pay close attention to, and that's from a nursing standpoint, that's from a respiratory standpoint, as you're assessing your patients from a respiratory standpoint. Why is the vent alarm going off? You see the patient clenching down on the ET tube. Is this patient in pain? So it's a multifaceted approach. And PTOT, this also affects you as well. Spontaneous awakening and breathing trials. So we put a initiative in place to help with this, right? You see charts all along the windows in each room, because we know that timely SATs, timely spontaneous breathing trials, timely extubations, those patients do better. The more days they spend on the ventilator, the more ICU days they have, the more deconditioning they have, the more cognitive, physical, mental, social issues that they have. And so that's why we're trying to get our patients going early on our spontaneous awakening trials. From a local level, we have talked a lot about this. We put some protocols in place, but this is why we're doing it, right? To really try to affect change here. Kudos to you guys in the first few months that we have implemented this. You've done a beautiful job. We had a jump in the number of timely planned extubations, right? We've fallen off a bit. When you go around the unit, and I was going around the unit this past weekend looking at those charts, you know, we've veered away from utilizing those charts. When those 3 a.m. rounds hit, making sure we're identifying proper patients for SAT, SBT, noting what time we started our spontaneous awakening trials, what happened if they failed it, noting when we started our SBT trials, noting what happened if they didn't pass. So we need to get back to that, because I know you guys can do it. We've done a really good job with that historically, and we can get back to doing that. I think we can really affect change here and really help our patients out. Choice analgesia. So we've done some work in this area as well, right? We've talked at, again, the local leadership level about ways to help make sure that our patients are comfortable yet lightly sedated, okay? Because we know that the more days the patients are deeply sedated, that also increases their ICU days, time on the ventilator, worsens deconditioning, all these things. So really what we try to do here is use sedation, be mindful of the sedation we're using, keeping patients on the lighter side of analgesia and sedation, so we can start waking those patients up in a timely manner. I would love for you guys to take a close look at this graph, because this graph really highlights one of the things that lengthens our patient's time on the ventilator in the ICU. My big comment here is that, as you can see, there is a difference between normal sleep patterns where the patient's awake during the day, and then at night they slip in and out of REM sleep, okay? And then when a patient is sedated in the ICU, you can see even during the day, they have all these fluctuations, and even going into the evening, and you see how many times the patient actually hits REM sleep during a normal sleep pattern versus when they're sedated. They hit that less amount of times in that restorative sleep. This worsens delirium. This leads to more time on the ventilator. So my big comment here is that there is a big difference between a patient being asleep and a patient being sedated, okay? So this is an issue that happens at night and during the day. So both shifts, right? At night, I know the patient looks a bit restless and everything, but when we use sedation in terms of letting them sleep, a patient's actually not asleep, they're sedated, and we run into this issue, okay? During the day, we have patients that are sleeping, lights are off, blinds are closed, and so during the day, this cycle gets thrown off a bit. So on both shifts, we should be mindful in terms of how patients' sleep-awake cycle looks, right? So that is in terms of the sedation that we're using, in terms of what we're doing during the day. During the day, blinds up, lights on, stimulating, hey, let's be up and at 'em. During the nighttime, blinds closed, lights off, and all that, right? And then again, in terms of sedation. I know this isn't a black and white thing. I know there's challenges along the way. I know there's patients that like to do karate in the bed at 3 a.m. But in general, this should be in the back of everybody's minds because this is something that's going to help with our outcomes. Speaking of which, delirium, we want to make sure that we're doing those things in order to help with that. Unfortunately, we see this quite often. Patients with ICU delirium, we want to make sure that we're using the medications that either prevent this or staying away from medications that really lead to stuff like this. So sedation, anticholinergics, want to be mindful of the amount of those medications we're using. We want to make sure that we're assessing our patients early and frequently for delirium, and if we see some changes there, making sure that we're addressing that early because we know that this increases length of stay. Early mobility, the closer that we can mimic a patient's lifestyle being home, the better that they can do. So getting our patients up early and often, and this includes trach patients, just at sometimes, being able to sit them up by the bedside, feet dangling, you're sitting next to them or you're standing next to them, holding them up, supported, getting them going early, getting family involved is often helpful in terms of range of motion activities, that sort of thing, passive range of motion, sitting, standing, ambulation, just keeping our patients up and moving all the time. That's something that's going to really help our throughput. Family engagement. So the way that we helped, kind of address this is that day 4 review that we started talking about, and we started trying to implement during our interdisciplinary rounds. Providers have slipped away from that, and we need to hold each other accountable and making sure that that happens, right? So part of that day 4 review is those patients that have been here in our ICU, especially the intubated patients at day 4, day 8. We want to make sure that we're identifying those patients on rounds, and we have a whole checklist that we have compiled to make sure that we have all the essential elements that are that are making sure that we're progressing that patient's care. One of the big elements is making sure that the providers have sat down and talked with the family about where we're at, where we're going, what we're doing, trach talks and everything. Hold us accountable, okay? If that's not happening, hold us accountable, especially the day 4 part. There's been a lot of RLs placed that pertain to this, right? So patients that have gotten extubated and the providers didn't have the foresight to make sure Dobhoff was in place, to make sure the patient's continuing to get enteral nutrition, if they're a little weak and they can't swallow when they're first extubated. Family meetings, being on the same page with the patients and the families. So all that needs to be taking place. So that day 4 review becomes vitally important. This is a checklist, a flow sheet that I think is, Katie, being implemented or already in place?
It's already in there.
Already in place. This is going to help ensure, it's like a checklist, making sure that all the elements are being done, we're holding everybody accountable, holding each other accountable, making sure that all the things are being done. If something's off with this checklist and this flow sheet, we need to address that. So everybody can take a look at this. And then, like I said at the beginning, if we're making sure that we are addressing each of the elements of the A to F bundle, our patients do better, our patients get out of the ICU quicker, our patients have better outcomes. But I kind of already mentioned this already, where we're addressing this from the local level. There's a lot of different moving parts in place. But there are a couple of different other committees, subcommittees that we have in place now that are making sure that we are doing all the things to advance the patient's care. We have a sepsis subcommittee, we have a nutrition and GI, we have a transition to care subcommittee. So we have all these different subcommittees now that are really focused on different aspects of the patient's care in the ICU. I think what I'll do at some point is kind of list out the subcommittees and post them somewhere. It takes a village. So if you guys see a subcommittee when that list is printed that you're saying, oh, that's interesting, and you have a vested interest in that and you want to help us out in terms of joining that subcommittee, helping to make decisions, helping to look at certain metrics as it pertains to our patients in the ICU, definitely feel free to approach myself, Jenna, Brett, Melinda, in terms of expressing interest in joining one of these subcommittees, because we could use some help. But this last slide is just kind of emphasizing that it kind of takes a village in order to make sure that all these things are being done. And the last kind of thing that I'll lead you with is that over the past couple of months, you guys done an excellent job in terms of managing our ICU patients. I've seen a lot of good work here. I know there's a lot of moving parts right now, but we had, I've been a part of a couple of meetings in the past couple of weeks. We have all these different ideas in terms of helping to affect change here, but we want to make sure that we are being effective in the processes that we already have in place. So what we don't want to do is be so scatterbrained and have all these different initiatives going on that we're not being effective in the things that we do have in place. So for right now, what we want to do is kind of focus on the basics, shore up what we have in place now, and really affect change that way, okay? So that's what we're going to do. So we don't want to kind of overwhelm and do all these different things and be all scatterbrained. We're going to try to focus in on what we're doing right now. And these couple of initiatives that we already put in place, I feel like if we can really get those down, especially the SAT, SPT protocols, we can really affect some change. So we'll continue to do that, but I just want to leave you with, you guys are doing a great job. I believe that this is a great, excellent team. But if you guys have any questions, comments, concerns on anything, I always want you to feel free to reach out to us, and we'll talk that out a bit. But the main things I want to leave you guys with besides that is that on every shift, just making sure that we're asking the right questions, especially during handoffs. Where are we at with the SAT, SPT protocol? Has this patient gotten up and moving? Is this patient on light sedation? If not, is there a reason for that they're on deeper sedation? Moving the patient. Those are all things that should be going through everybody's mind on a daily basis. All right. I think we ran over. I'll be mindful of your time. But if there's any other further questions, come find me. Concerns, come find me. There's my email. And all that. All right. Clear as mud.